Welcome to RXology. We're deep diving into one of the most widely prescribed drug classes in the world, ACE inhibitors. Understanding how they work is absolutely essential for your board exams and clinical practice. ACE inhibitors are everywhere: hypertension, heart failure, post-MI, diabetic nephropathy, even migraines. Their mechanism ties directly into one of the most important physiological systems you will ever learn, the renin-angiotensin-aldosterone system, or RAAS. By the end of this video, you will understand how ACE inhibitors work, their side effects and why, which patients should never receive them, and clinical pearls about specific drugs that are very testable. Naming tip before we get started: every ACE inhibitor ends in pril: Lisinopril, Ramipril, Enalapril, Benazepril, Captopril, all of them. Let's walk through RAAS step by step. RAAS is the body's built-in system for raising blood pressure when it senses a threat, such as low blood volume, low sodium, or low renal perfusion. Here's the pathway. The kidneys detect decreased perfusion pressure or low sodium at the macula densa. In response, the juxtaglomerular cells in the afferent arteriole release an enzyme called renin into the bloodstream. Renin acts on angiotensinogen, a protein made by the liver that circulates in the blood. Renin cleaves angiotensinogen into angiotensin 1. Angiotensin 1 is inactive; it is only a precursor. Angiotensin 1 travels to the lungs, where it encounters angiotensin-converting enzyme, or ACE. ACE is found primarily on the endothelial surface of pulmonary capillaries, but it is also present in the kidneys, brain, and other vascular beds. ACE cleaves 2 amino acids from angiotensin 1, converting it into angiotensin 2, the most powerful vasoconstrictor the body can produce. Angiotensin 2 does several things simultaneously. It directly constricts arterioles, raising peripheral resistance and blood pressure. It stimulates the adrenal cortex to release aldosterone, which tells the kidneys to reabsorb sodium and water, which increases blood volume. It stimulates ADH, or vasopressin release from the posterior pituitary, further increasing water reabsorption. It stimulates thirst. And at the kidney, it preferentially constricts the efferent arteriole of the glomerulus, which increases filtration pressure. The net result of angiotensin 2 is blood pressure goes up through vasoconstriction, volume expansion, and increased cardiac output. ACE inhibitors competitively block the ACE enzyme, which prevents the conversion of angiotensin 1 to angiotensin 2. With less angiotensin 2 in the system, you get vasodilation, because the vasoconstrictor is reduced. Decreased aldosterone secretion, so the kidneys excrete more sodium and water, reducing blood volume. And reduced efferent arteriolar constriction in the kidney, which lowers glomerular filtration pressure. This is why ACE inhibitors are renal protective in diabetic nephropathy. ACE does not only convert angiotensin 1 to angiotensin 2, it also breaks down bradykinin, a potent vasodilator peptide. When you inhibit ACE, bradykinin levels rise. This increased bradykinin contributes to the blood pressure lowering effect, but it is also directly responsible for 2 signature side effects: the persistent dry cough and angioedema. Remember this dual role of ACE: it converts angiotensin 1 and degrades bradykinin. This explains why ARBs, angiotensin receptor blockers, share the blood pressure lowering effects but have a much lower incidence of cough and angioedema. ARBs block the angiotensin 2 receptor directly and do not affect bradykinin metabolism. Side effects are predictable in pharmacology because they directly trace back to the mechanism. If you understand the RAAS and the bradykinin pathway, you can predict every one of these. From RAAS inhibition, you get hypotension. You are reducing vasoconstriction and blood volume simultaneously. First-dose hypotension is particularly common in patients who are volume depleted, for example, patients on diuretics. Clinical pearl: start low, especially in patients already on a diuretic or with heart failure. Some providers hold the diuretic for a day or two before initiating the ACE inhibitor. For hyperkalemia, ACE inhibitors suppress aldosterone, which reduces potassium excretion. Potassium levels can rise. This is clinically significant in patients with chronic kidney disease or in patients taking potassium-sparing diuretics such as spironolactone. Monitor potassium levels after initiation and with dose changes. AKI. ACE inhibitors dilate the efferent arteriole, which decreases glomerular filtration pressure. In a healthy kidney, this is beneficial. But in patients whose kidneys depend on efferent constriction to maintain filtration, specifically patients with bilateral renal artery stenosis or severe volume depletion, ACE inhibitors can cause a dangerous drop in GFR and acute kidney injury. A rise in serum creatinine of up to 30% from baseline is generally acceptable and expected when starting an ACE inhibitor. If creatinine rises more than 30%, discontinue the drug and evaluate. From a buildup of bradykinin, you get dry cough, which is the most common side effect, affecting approximately 5 to 20% of patients. It is a persistent, dry, non-productive hacking cough caused by elevated bradykinin levels in the lungs, which stimulates airway sensory nerve fibers. The cough can appear within days or weeks of starting, or even months later, and resolves within 1 to 4 weeks of stopping the drug. This is the #1 reason patients are switched from an ACE inhibitor to an ARB. Angioedema is rare but potentially life-threatening. Angioedema presents as non-pitting, asymmetric swelling of the face, lips, tongue, and upper airway caused by bradykinin-mediated increased vascular permeability. It can occur at any time during therapy, not just with the first dose. If a patient develops angioedema on an ACE inhibitor, discontinue immediately and never re-challenge with any ACE inhibitor. Some other side effects include a black box warning for teratogenicity, so ACE inhibitors are contraindicated in pregnancy. Exposure during the 2nd and 3rd trimesters is associated with fetal renal dysplasia, limb contractures, and fetal death. The mechanism relates to impaired fetal renal development from loss of angiotensin II-mediated efferent arteriolar tone. If a patient becomes pregnant while on an ACE inhibitor, discontinue immediately. This is a list of contraindications of the patients who should not receive ACE inhibitors. Pregnancy. See black box warning. History of angioedema with an ACE inhibitor. Never re-challenge. This also includes patients with hereditary or idiopathic angioedema. Bilateral renal artery stenosis. In these patients, both kidneys depend on efferent arteriolar constriction by angiotensin II to maintain GFR. Block angiotensin II production, and you can precipitate acute kidney failure. This is a classic exam question. A patient starts an ACE inhibitor and presents with rising creatinine. Always think bilateral renal artery stenosis. Hyperkalemia. ACE inhibitors will worsen it. Use caution with potassium-sparing diuretics or potassium supplements. Concurrent use with aliskiren in diabetic patients, or with a neprilysin inhibitor such as sacubitril. Do not combine an ACE inhibitor with sacubitril valsartan, known as Entresto. Wait at least 36 hours after stopping the ACE inhibitor before starting Entresto, because the combination dramatically increases the risk of angioedema from excessive bradykinin accumulation. Lisinopril is the most commonly prescribed ACE inhibitor in clinical practice. It is FDA approved for hypertension, heart failure, and acute myocardial infarction. Lisinopril is one of only 2 ACE inhibitors, along with Captopril, that is not a prodrug, so it does not require hepatic activation. This means it is a better choice in patients with significant liver dysfunction. It is dosed once daily, which improves adherence. Enalapril is a prodrug that is converted by the liver to its active form, enalaprilat. This distinction matters in 2 scenarios. First, enalaprilat is the only ACE inhibitor available in an IV formulation, making it the ACE inhibitor of choice when IV RAAS inhibition is needed, such as in hypertensive emergencies when oral medications are not an option. Second, because enalapril requires hepatic conversion, its onset is slightly slower than lisinopril or captopril. Enalapril was the ACE inhibitor studied in the landmark Consensus and Solved trials, which established ACE inhibitors as foundational therapy in heart failure with reduced ejection fraction. Ramipril is the ACE inhibitor studied in the HOPE trial, one of the most important cardiovascular prevention trials ever conducted. It showed that Ramipril significantly reduced the rates of MI, stroke, and cardiovascular death in high-risk patients who did not have heart failure or low ejection fraction. This established Ramipril as the ACE inhibitor of choice for secondary cardiovascular prevention. Patients with diabetes plus another risk factor, peripheral vascular disease, or a history of coronary artery disease. If a question gives you a high-risk cardiovascular patient without heart failure who needs an ACE inhibitor, Ramipril is the evidence-based answer. Captopril is the original ACE inhibitor and not used much these days. It has a short half-life, so typically dosed 2 to 3 times daily, which makes adherence more challenging. Like Lisinopril, it is not a prodrug, so it does not require hepatic activation. What makes Captopril unique is its sulfhydryl group. This is responsible for its unique side effect of dysgeusia or metallic taste. The sulfhydryl group chelates zinc, which is thought to alter taste perception. Captopril is also the ACE inhibitor best studied for diabetic nephropathy and type 1 diabetes, and it was used in the landmark SAVE trial, which demonstrated mortality benefit after MI in patients with left ventricular dysfunction. Clinical Pearl. Captopril should be taken on an empty stomach because food reduces its absorption by 30 to 40%. Let's go over some important review points. 1. Monitor potassium and creatinine. Check a baseline metabolic panel before starting, then recheck within 1 to 2 weeks. A creatinine rise up to 30% is acceptable. Greater than 30%, stop the drug and investigate. 2. Dry cough means switch to an ARB. If a patient on an ACE inhibitor develops a persistent dry cough, the standard move is to switch to an ARB, which does not affect bradykinin metabolism. Do not switch to a different ACE inhibitor. This is a class-wide effect. 3. Angioedema is an absolute contraindication to rechallenge. If a patient develops angioedema on any ACE inhibitor, they should never receive any ACE inhibitor again. An ARB can be used cautiously as an alternative, as the cross-reactivity rate is low but not zero. 4. ACE inhibitors are contraindicated in pregnancy. If a board question gives you a pregnant patient with hypertension, ACE inhibitors and ARBs are the wrong answer. Labetalol or nifedipine are the safe alternatives. 5. Bilateral renal artery stenosis plus ACE inhibitor equals acute kidney injury. This is a classic exam trap. The patient's kidneys depend on angiotensin II to constrict the efferent arteriole and maintain GFR. Remove angiotensin II and filtration drops. 6. Consensus and Solved established Enalapril for heart failure. The HOPE trial established Ramipril for cardiovascular risk reduction. The SAVE trial showed Captopril's benefit post-MI with LV dysfunction. 7. Do not combine with neprilysin inhibitors. If switching a patient from an ACE inhibitor to Entresto, you must wait at least 36 hours to avoid the risk of severe angioedema. Let's recap. ACE inhibitors block the conversion of angiotensin I to angiotensin II, reducing vasoconstriction, aldosterone release, and blood volume. The side effects, hypotension, hyperkalemia, cough, angioedema, renal injury, all trace directly back to blocking RAAS and accumulating bradykinin. For your exams, remember, check potassium and creatinine after starting. Never use in pregnancy. And if a patient gets a cough, switch to an ARB. If this helped you, hit that subscribe button and turn on notifications so you can master your pharmacology. Drop a comment with which drug class you want next. I'll see you in the next one.